Hello again. So in this video we are going to be talking about the management of hyponatremia, and I hope that you have had a chance to review the video that I made about the various causes of hyponatremia and the workup of hyponatremia that can direct you towards the cause. And once you know the cause, then you can treat it more appropriately. If you have not had a chance to review that video, I'm going to provide you a link here, and you can click that link. I strongly recommend that you watch that video. Okay, so we're talking about management, and when it comes to management, the number one thing that we need to remember is that we do not correct hyponatremia rapidly. That is a point that cannot be overemphasized in clinical practice in both questions. This is one thing that you need to know. So the first thing is that what is the rate of correction? And the answer would depend on whether the patient is acutely symptomatic or not. But even if the patient is acutely symptomatic, we do not, in that case, you correct rapidly, but the 24-hour correction level would not exceed beyond a certain amount. And we are going to talk about that briefly. Now, so what happens in hyponatremia? So why is hyponatremia such a problematic condition? So when the hyponatremia occurs, it leads to cerebral edema. Now, it leads to cerebral edema, and the degree of cerebral edema depends on the acuity of hyponatremia. So if hyponatremia has developed rather quickly, patients can become symptomatic very quickly. What are the symptoms of cerebral edema and hyponatremia? The symptoms are altered mental status, confusion, and seizures. And left untreated, hyponatremia is going to be a fatal condition. So it is a serious condition, and it needs to be treated quite aggressively. Having neurological symptoms is one of the reasons to be a little bit more aggressive in acute treatment. Even then, as I mentioned, your rate of correction for 24-hour period and 48-hour period should be in a certain limit. Now, so again, avoid rapid correction. This is something that we just discussed, and we'll discuss it more. Now, what happens if you correct rapidly? If you correct rapidly, then it leads to osmotic demyelination syndrome, or we used to call it pontine demyelination syndrome. Because pons is the area of the brain that most commonly gets affected if there is osmotic demyelination, and patients who have pontine demyelination or osmotic demyelination, they present with paraplegia, quadriplegia, even locked-in syndrome, and they can present a few days after you had treated them and discharged them home. Okay, so let's talk about the rate of correction. So for acute symptomatic hyponatremia, and again, symptomatic means that they are having seizures, confusion, altered mental status. You want to bring up the sodium quite rapidly, and for those patients, you use hypertonic saline, and you can correct at a rate of 1 to 2 milliequivalents per hour for a total of 4 to 6 milliequivalents correction in the first 6 hours. Okay. So an important thing here is that one thing is that if, let's say, someone has a sodium of 115 and they are having seizures, you give them hypertonic saline and you corrected them at the appropriate rate, and you have brought it to 121 at the end of 6 hours. Now, the sodium has not normalized, but it is very important to understand that this 6 milliequivalent difference is enough to treat their symptoms and to bring them out of the danger zone. Now, The hyponatremia, of course, needs to be treated, but at this level you will stop and you will keep them maintained at this level for 24 hours before trying to correct further. And that again goes back to our basic principle of treating hyponatremia, that you do not treat overly rapidly. Okay, one thing that I should have mentioned, and I probably it's a good idea to mention it right now, is that how do you define the severity? So the severity of hyponatremia is defined as mild. Normal sodium is 136 to about 146. Some labs say 148, but that's the normal sodium. So mild hyponatremia is a sodium level of 135 to 130. Okay, and then moderate is considered 129 to 125, and profound is considered any level which is less than 125. Okay, and of course symptomatic hyponatremia simply means seizures and mental status changes, and generally we think about severe hyponatremia generally means profound hyponatremia and seizures. Okay, so coming back, that we have acute symptomatic hyponatremia, and we give them hypertonic saline, and you brought up their sodium by 6 millicoulombs in for 6 hours. Okay, how do you bring that up? So you give them hypertonic saline, and so for hypertonic saline, how much do you give? So, well, in the acute condition, you can give IV bolus of maybe 50 to 100 ml of hypertonic saline, and obviously you need to monitor sodium quite closely, and in those patients you should check sodium maybe every hour, if not every hour, then maybe every 2 hours, but not less frequent than that. If your sodium has come up but has not come up to your desired level, then you can again repeat a dose of hypertonic saline, 50 to 100 ml. Now, in patients who have CHF, the use of hypertonic saline, and hypertonic saline, can lead to fluid overload, water retention, and in those patients, the use of hypertonic saline with diuresis has proven to be associated with a better outcome, and that should be considered in patients who have CHF. Okay. Now, some authorities also believe in treating with hypertonic saline if patient has sodium level of less than 120 and they are asymptomatic. Okay, so of course if patient is symptomatic, then you treat with hypertonic saline. That's a given. But if sodium level is severely low, then some authorities do believe in giving hypertonic saline even if the patient is asymptomatic. And in those patients, you can again give a bolus of 50 ml, and you can also run the drip at about, I want to say, 15 to 20 ml per hour, again with close monitoring. And some authorities also give that along with desmopressin and diuretics. Okay, so what is the rationale of using desmopressin? So desmopressin is again ADH agonist, right? So if it's an ADH agonist, you would think that it will lead to more water retention, and would not be a good idea if you use it in patients who are being treated for hyponatremia. And the rationale behind using desmopressin with hypertonic saline is that it prevents rapid overcorrection. So giving them hypertonic saline, that would almost ensure that you would not, well, shouldn't say almost ensure, but it would at least be a safety net, so to speak, that would prevent overly rapid correction. And then, of course, diuretics is another thing which would help with the hyponatremia part. Okay, now all this stuff that I just mentioned about asymptomatic hyponatremia and sodium of less than 20, from the board standpoint, I think that they would not expect you to go into that much detail. I just want to let you know, just to help you with some practical points in hospital rounding and treating hospitalized patients. I would strongly encourage that if you are having this problem and any patient with hyponatremia, you get nephrology consult on board to help. But from this presentation and from board standpoint, you should know when to use hypertonic saline. And as we discussed that you can use hypertonic saline in patients who have profound hyponatremia who are symptomatic. You should know what is the appropriate rate of correction of hyponatremia, and that we have been talking about since the start of this presentation. And of course, I'll tell you what you need to do if you have overly corrected. Okay, moving forward. So for chronic hyponatremia, and we're talking about chronic hyponatremia, but patients are not symptomatic right now, then your rate of correction is not more than 8 milliequivalents in first 24 hours and not more than 16 milliequivalents in 48 hours. Now, so these are important to remember, but important thing to remember is that these are upper limits of the recommendation. Meaning that if you have corrected sodium of, like, let's say 6 milliequivalents in 24 hours, it does not mean that you have done anything wrong. But if you have corrected the sodium even like 10 milliequivalents in first 24 hours, then that would be not according to the guidelines. So remember that this is the level of correction, and and these are the upper limits of the normal. Okay. And then you treat according to underlying cause. So again, our slide. Our previous presentation on causes of hyponatremia should have given you enough confidence as to what is the cause of hyponatremia that you're treating. Simple as that if they have volume depletion, you give them IV normal saline and or salt tablets, and that should suppress the ADH enough that the sodium would correct. And this is by far the simplest way to treat hyponatremia, or by simplest etiology of hyponatremia to treat. Now we talk about hyponatremia due to fluid overloaded states such as CHF and cirrhosis. So again, in these patients, we treat hyponatremia by treating the underlying cause, which is CHF and cirrhosis. As you already know, that in both of these conditions, there is a strong activation of renin, angiotensin, aldosterone pathway. Also known as the RRA system. So in those patients, obviously treat the underlying condition by diuresing them. We give them diuresis. You also put them on a salt-restricted diet. You also put them on a fluid-restricted diet, and that by itself should help correct hyponatremia. So salt and fluid restriction, diuresis, again, these are your cornerstone of treatment for hyponatremia in CHF and cirrhotic patients. Okay, so let's say that you have done all this. Oh, by the way, you also have to do renin RRA pathway blockage, which we achieve by ACE inhibitor or ARB, and those have been shown to help in CHF specifically, but of course you can use in cirrhotics as long as there is no renal failure or renal dysfunction, which can happen in cirrhotics quite commonly. But if you have tried all this, then there is a role of vasopressin antagonist. Okay, so vasopressin antagonists. So what are those? So vasopressin antagonists, they are substances which block the receptors in the kidneys. The ADH receptors in the kidneys. So in US we have two types of vasopressin antagonists available. One is tolvaptan, and this is an oral formulation, and 12-web10, it affects the V2 receptors of ADH. And then we have an IV formulation, which is coniveptan, and this affects the V2 and V1A receptors. Knowing the receptors is not that important. Just remember that what are the names and whether they are oral or IV. Okay. So obviously, since they are ADH antagonists, then they are going to inhibit free water retention at the level of the kidney, and obviously that would fix your sodium. Okay. Now, it's good to know, but at an internist level, I would highly suggest that you do not start a patient on that. You always get a nephrologist consult, and you can suggest to them if vasopressin antagonists are indicated in these patients. And of course, if there is a CHF specialist on the case, then of course they can also decide. It's good to know because it's in the guideline, and it's good to know that this is some additional thing you can use to treat the hyponatremia in these patients. And the board can of course ask you about this, but you should know about the limitations of these agents. Okay, so these agents, of course, almost is like a magic drug. You put the patient on them, and they will correct the hyponatremia. But you need to know what are the limitations of these drugs. Okay, so we are going to talk about the limitations of these drugs, and the biggest limitation of these drugs is the hepatic injury. So they can lead to quite dramatic and sometimes fatal increase in the LFTs. And that's the biggest concern, and that is one of the reasons why you do not want to give these agents in cirrhotic population. In real practice, I have seen some of the liver specialists and transplant surgeons using it to get the patient tuned up for surgery. But from an internist standpoint, it's important to know that these agents cause hepatic injury, and at this point, you should not be putting cirrhotic patients on them. Okay. What is the other side effect? It can correct sodium very rapidly. So again, the overly rapid correction of sodium that we have been worried about since the beginning of this presentation. That's because of course it's blocking the ADH receptor in the kidney, and it's going to just inhibit the free water retention or free water absorption, and that it's definitely something we want to avoid. So it can correct sodium very rapidly. Cost is another issue that these patients, these medicines are costly, and that's another reason, which is almost kind of reason why we don't want to use that very commonly in general practice, especially when we have simpler, less costly, and less dangerous methods of fixing the sodium, such as salt and water fluid restriction, diuresis, RAA pathway inhibitors. And lastly, they increase the thirst mechanism. So because of that, if the fluid is not restricted, then it can limit the rise in sodium because of increased thirst. The patient will drink more water, and that can prevent the sodium from getting up. Okay, so enough about this. Always remember that if you do prescribe someone tolvaptan, they should not be on tolvaptan for more than 30 days. Okay, so again, really, I think that in a nutshell, it's the bottom line is that you should know that these agents are available for hyponatremia treatment, but there are many of the limitations, and you should be aware of that. So again, just to kind of conclude, what are the specific conditions in which these agents can be used? So the specific condition in which these agents can be used is if you have a sodium of less than 120, and provided they are not symptomatic, because in that case you will do hypertonic saline, and those patients are on diuretics and are on the RAA inhibitors, and they have CHF, and they have no liver disease. In those cases, you can say that, okay, well, now ADH antagonist can be used. Okay, enough about that. We'll move forward. So now we have SIADH. So again, in SIADH, in our presentation about the causes of hyponatremia, we mentioned so many causes of hyponatremia in SIADH. In hyponatremia due to SIADH, you want to treat the underlying cause. For example, if it's pneumonia, you want to treat the pneumonia. If it's a drug, you have to withhold the drug, and so on and so forth. By the way, so whenever you try to treat hyponatremia, you should always review the medicines and take away the medicines which cause hyponatremia. And as I mentioned, that hydrochlorothiazide is an important one, and SSRI is an important one, and NSAID. These are all important drugs that you should take the patients off when you're trying to predict their hyponatremia. Okay, so for SIADH, you treat the underlying cause, and if you restrict fluid. So if the patient is on IV fluids, you DC IV fluids, and you restrict their fluid. You do not restrict their salt. Okay, so fluid restriction, other than treating the underlying cause and stopping the offending agent, such as the medicine which they might be taking, fluid restriction is really the cornerstone of treatment for SIADH. In hospital patients, many patients are put on normal saline as a treatment of hyponatremia. But you have to understand that if patient has SIADH, they have excess ADH. So what will excess ADH do? So all the normal saline that you are giving in the body, ADH would make all the free water from that normal saline retain in the body, and the salt will be lost in the urine, and as a result, even given the normal saline, would make their sodium would drop their sodium more. So fluid restriction is important. Okay, and you do not restrict salt. So let's say that you have treated the Lyme condition, you have removed the offending agent, you have restricted their IV fluids, and still they are hyponatremic. You can give them salt supplements, salt tablets, sodium chloride tablets. They can be given like 650 milligram tablets. They can be given 1 or 2 tablets. I start with 1 tablet twice a day. Of course, that can be increased 1 or 2 tablets 2 or 3 times a day. But 2 tablets 3 times a day is a lot of salt. So I just generally restrict to 1 tablet. But salt supplements, you can give them furosemide, loop diuretics. Okay. And now let's say that you have tried all that and it's still not working. Then you can think about vasopressin antagonist with all the considerations about treatment with vasopressin antagonist that we discussed earlier. Keep that in mind and make your call in the right clinical scenario. And then we talk about dimethylcycline can be used. Okay, so what is dimethylcycline? Well, dimethylcycline is actually a tetracycline antibiotic, but what it does is causes nephrogenic diabetes insipidus. Okay, and of course, since this nephrogenic diabetes insipidus, it causes free water loss from the kidney, and that would raise your sodium. Okay. At this point, let me clarify one thing. Many students and residents seem to be confused between desmopressin and dimethylcycline. Okay, so again, to recap, desmopressin is an ADH agonist. And as an ADH agonist, it causes free water retention and hyponatremia. Okay, and desmopressin is therefore used in cases of hypernatremia, such as we have diabetes insipidus due to central causes that we will cover in the video on hyponatremia. Okay, so that's desmopressin. So what is dimethylcycline? Dimethylcycline is a tetracycline antibiotic, and again, it is used in infectious causes, but it can cause nephrogenic diabetes insipidus as a side effect, and that's why it is used off-label really, but it is used in SIADH to almost induce a condition of diabetes insipidus. So demeclocycline in effect is going to raise sodium. Okay, so that is in contrast to what desmopressin can do. I wish that they just change the names, because the names are also kind of so similar sounding that of course the confusion is understandable. And demeclocycline is therefore used in cases of hyponatremia. Okay, so that's just a clarification on what demeclocycline and desmopressin are. Okay, and that's for SIADH. Okay, very important. What if you rapidly corrected sodium? So again, like we discussed, in that case, you need to give them demeclocycline or desmopressin, because that's going to be an ADH agonist and would prevent sodium from dropping further. But desmopressin by itself is going to prevent sodium from dropping further, yes, but it would not drop the sodium, and you have already overcorrected the sodium. So you need to bring sodium down a little bit, and that you accomplish by D5W, and again you do close sodium monitoring. In real world hyponatremia, it can be underestimated by some of the physicians and even by the nursing staff, and they might not understand why you have to check the labs so frequently in patients with hyponatremia and why you're doing so many different things. But it's very, very important to keep these things in mind and know the implications of over treating or not treating appropriately hyponatremia. Okay, so we are going to move forward with some question. So here we have an elderly patient who comes with pneumonia. Just first line should give you a tip off that we are dealing with SIADH here, most likely. And again, this patient is on normal saline, as is the norm in the hospital, at 100 cc an hour. And if this patient has SIADH, then we can expect the sodium to drop. Sodium was normal on admission, and 3 days later, the pneumonia has been treated quite appropriately because the WBC count is better and the patient is AFib-wise. However, he's now confused. Now he's a seizure, and sodium is now 115. Of course, in real world, I would have been checking their lab on a daily basis, but it has happened that patient is here with pneumonia and no one checked their lab for 2-3 days. Anyway, sodium is now 115, and serum sodium is not given, but let's assume that serum osmolality is low, and creatinine is normal, and urine osmolality is high, and sodium is high, which are the telltale findings in SIADH. We diagnose it as SIADH. So how would you treat this patient? Okay, so remember that he's on normal saline. We need to stop that. He's seizing. We need to give them hypertonic saline, and the answer is that with DCIV fluid and start hypertonic saline. You can start diuretics as well, but really this is something that we use more for CHF patients. But yeah, you can give them diuretics as well, and that would also help with the sodium. Okay, let's say that the sodium had dropped to 120 and the patient was not seizing. In those cases, you would have stopped the fluids, put them on fluid restriction, maybe give them salt supplement and diurese them, with of course close sodium monitoring, like we discussed. Okay, this is about it for the management of hyponatremia, and I hope this video was helpful for you. Just some last minute thoughts are that at what level, so hyponatremia and perioperative or preoperative clearance. So what's the deal there? So remember that any degree of hyponatremia is associated with a high post-op mortality. So, as a medical consultant, you can be asked to consult on a patient for hyponatremia, and one of your jobs might be to, so to speak, quote unquote, clear the patient for surgery. So I want, you to know that there was a study published in, I want to say, well, I don't want to say the wrong journal here, but the study showed that in patients who had normal sodium, the all-cause mortality post-operatively, I think, was 1.3%, and patients with any degree of hyponatremia, and by any degree of hyponatremia means sodium of 135 or less, those patients had a mortality of 4 point something percent. So of course, more than double the mortality, and as the degree of hyponatremia gets worse, and remember that we talked about mild, moderate, and profound, the mortality increases. So, just something to keep in mind, and I, ideally would like their sodium to be more than 135 before clearing them for surgery. And in current medicine, you have a lot of tools you can use to correct the sodium before clearing them for surgery. And number two is that when to hospitalize patients with hyponatremia. Of course, I would let you use your own discretion, but generally any sodium below 130, I do not like to treat that as an outpatient. And if you're an ED physician, I would suggest that you admit those patients for workup. Of course, your decision can be criticized in individual cases depending on what the cause of hyponatremia. All right. Thank you.